Thank you,
Thank
sir,
you,
for coming.
chairpersons. First of all, let me thank all the organizers, Akash Singh sir, Bansi sir, Kamaldeep Chawla sir, Dishang bhai, Sushil bhai for inviting me here. I'm thankful to my teacher, Dr. Panikar sir also, because of whom I am here and giving talk in front of you. Thank you, sir, again. And a topic given to me is little bit different from what we talk every day. And I'm thankful to the scientific chair because they have kept a cardiologist, a well-known cardiologist, again to answer just a talk after me. So I would request Kamaldeep sir to answer questions in the session because this is a topic where we usually practice less. In a simple OPD, our as a diabetologist or a physician, our work is finished once we write down statin. Okay, we don't think much after that. But let's talk something beyond statin and why we are discussing, because in India, if you see the metabolic conditions, we know diabetes is increasing day by day, but apart from obesity and hypertension, high LDL cholesterol is still very prevalent. 1 in every 5 patients has high LDL cholesterol, and the increased risk of ACVD that is well known. More LDL, more heterogeneity and more AFCD. This is very simple thing. There are numerous evidences to tackle with this. So no discrepancies in there. More LDL, more heterogeneity, small dense LDL is again worse. But overall we want to target LDL. Statin has been the mainstay therapy for key risk groups. Okay, from the beginning, if you see primary and secondary prevention for ASCVD, it has been there long standing and with robust evidences, both primary and secondary prevention. We have been using statin. We have been classifying them or grouping them according to the intensity to lower LDL. Low intensity statin, high moderate intensity and high intensity statin, depending upon the average LDL reduction they do, either less than 30%, 30 to 50%, or more than 50% LDL reduction. So we know all this, but the magnitude of problem for further LDL reduction in India is still there. Not only in India, everywhere it is still there. So what are the issues? We have now recognizing more and more cases of familiar hypercholesterolemia, and where only statin is not adequate. We have also a huge residual risk remaining even after giving statins. Okay, so despite patient on high intensity statin, there is sizable residual risk of ASCVD event even giving the highest tolerable doses of statin. There are a lot of patients now we recognize in our OPD about intolerant to statin and their side effects like myopathy and sometimes elevated transaminases. There is also a thing to note that only 20 to 30% patients are at goals despite giving the maximum tolerable statin. So this is again thing, only 20-30 patients. You can see here residual severe risk is likely due not only to lipid factors but also other risk factors in suboptimal control such as hypertension, diabetes and smoking. Also, patients with uncontrolled LDL cholesterol despite moderate or maximum dose of statin, they were only having 52%. So more than half of the patients, they are uncontrolled LDL gold. So that's why we need new tools. So we'll see a basic about all these newer molecules. Okay, apart I think before 5-10 years we won't be hearing these new molecules, but now they are everywhere. They are practically available in India also, and now they are getting used in our practice also as a diabetologist or a physician also. So what are there are so many tools available, starting with first with the ezetimibe. You must be knowing a very recently been popular molecule. It has been US FDA approval, daily and oral agent for LDL cholesterol lower. What is the mechanism? Very simple one. You can see it inhibits the intestinal NPC1L1 protein, and that's where it prevents the intestinal or biliary absorption of cholesterol. Okay, this is not anything related to the synthesis of cholesterol. It is preventing the intestinal absorption. So monotherapy achieves 18% lowering, when added to statin achieves additional 23 to 24% lowering, because when you add to statin we target two mechanisms, for synthesis also and reabsorption from the intestine also. Note, it is noted that it should not be used for moderate to severe hepatic impairment patients. We have data for them, IMPROVE-IT trials, where the 3-point MACE reduction was reduced significantly by 7% over and above simvastatin. Another molecule, PCSK9 inhibitors. What are they? So in simple words, liver has LDL receptors, okay, where LDL get purchased and absorbed to the liver from the bloodstream. So more LDL receptor, the lower the serum LDL level. So what does PCSK9 inhibitors? They are actually monoclonal antibodies and they inhibit PCSK9. That's why they block the degradation of LDL receptors. So more LDL receptors are there in liver, and that's where more blood-borne LDL is absorbed in the liver in simple term, and that's where the serum level of LDL cholesterol is reduced. So these molecules are FDA approved for LDL lowering and to reduce the MACE events in patient with already having atherosclerotic cardiovascular disease. The beauty of this is the efficacy in reduction LDL. It reduced up to 45 to 64% reduction. The issues are there. Being an antibody, it can cause hypersensitivity reaction, and there has been some association with new onset diabetes with evolocumab. They are costly and they need to be taken injectively. Either you can take every 2 weeks, or there are formulation for monthly injections also available. We have CV data are available for 4-year trial and Odyssey trial. You can see the 15% CV death reduction, MI, stroke, hospitalization for unstable angina or coronary revascularization. And similarly, Odyssey trial, there has been 17% reduction in CV, cardiac death, MI, ischemia, stroke and unstable angina hospitalization. Another molecule is the bempedoic acid. Again, this is a newer molecule in Indian market, relatively newer molecule, where it acts on the liver a step before the statin, where it inhibits the ATP citrate lyase enzyme, and that's why it blocks the LDL production. The different thing about this molecule is it is a prodrug, okay, and it is only activated in liver, so it doesn't work in the muscle. So this is the differential mechanism where we can have lesser chances of the others toxicity related to conventional statins. It is a daily oral agent, FDA approved for ASCVD and heterogeneous familial hypercholesterolemia also. There is a risk of increasing in the uric acid level and risk of tendon ruptures also. Again, if you see patient with persistent hypercholesterolemia, despite maximum tolerable statin, adding bempedoic acid reduces LDL cholesterol by up to 16% in Clear Harmony trial and Clear Wisdom trial up to 15% reduction. Patients who are unable to tolerate statin also, again you can see in the Clear Tranquility trial 23.5% LDL reduction and similar reduction in the Clear Serenity trial also. Now another interesting molecule is the PCSK9 mRNA synthesis inhibitor. Okay, so these are actually siRNA, so that is small interfering RNA. So these molecules, how they work, they go into the nucleus, and at the formation of the PCSK9 mRNA, it interferes the formation of the PCSK9 mRNA. So actually the protein formation is blocked. So that's where it works on the other mechanism reducing PCSK9. That's why it reduces the LDL receptors on the liver, and that's why it reduces the LDL cholesterol level in serum. And there is FDA approval for using this molecule in already patients having ASCVD or heterogeneous familial hypercholesterolemia, adjunct to diet and maximal tolerable statin in patients who require additional LDL lowering. Though it is a costly molecule available, the cost can go over 1 lakh rupees for a single injection. You have to give it once, then after 3 months, then every 6 months. Then Orion trials have shown the efficacy. You can see the change from baseline in LDL cholesterol of up to 50 to 60% and absolute LDL reduction about around 50 milligram per deciliter also. So in summary, what we want to discuss more, you have to take care about the side effects and warning and precautions, though they are available now. So ezetimibe, most common adverse effects are URTI, diarrhea, arthralgia, sinusitis, pain in extremity, and it should not be used in moderate to severe hepatic impairment. Bempedoic acid also can cause upper respiratory tract infections, increased chances of muscle spasm, hyperuricemia, and sometimes elevated liver enzymes like statins. And the risk is of increase in serum uric acid, and there is increased risk of tendon rupture also with bempedoic acid. The PCSK9 inhibitors, okay, hypersensitivity reactions are very common, and there has been some association with new onset diabetes in with evolocumab. Inclisiran, it is the having injection site reactions, arthralgia, sometimes increased risk of uric acid, urinary tract infections, and diarrhea can be there. Another molecule we want to discuss, being a diabetologist or diabetic treating physician, is saroglitazar. Okay, it is a dual PPAR agonist, alpha and gamma both. Okay, and it reduces triglycerides also predominantly, and it reduces insulin resistance. Though triglyceride lowering, we have other molecules. Our main focus for this talk is LDL monitoring, but still saroglitazar needs additional mention here because it improves diabetic dyslipidemia. It has been approved in India, hypertriglyceridemia. It is approved for NAFLD and NASH also, and in India it has additional label indication for management of type 2 diabetes also. For lack of time, guideline recommendation let me skip. In diabetes and statin, okay, why are we using statin? So lipid lowering is the primary goal. We want to reduce atherosclerosis or even sometimes regress also. We want to improve CV outcomes of our patients, and it is recommended by guidelines. But LDL lowering is not the only key way. So message shouldn't go when we see newer molecules marketed by the companies, we start using it, but we forget the basics. So LDL lowering is not the only key step. What we are missing is the supportive treatment and lifestyle intervention. We are missing beyond statin, medical nutrition therapy, weight loss, physical activity, smoking cessation. These are very critical aspects when you take ASCVD, especially in diabetic patient. So we need to guide our patient. The previous session we were discussing insulin and education and monitoring. Again, when there is no education, no lifestyle changes, even the costlier insulin and even sometimes the pumps cannot help. So therapeutic lifestyle changes are very critical. Our patient needs to be in regular physical activity. Weight reduction again a key, which will definitely reduce triglyceride and increase HDL. Moderation of alcohol. Now we have some privilege in being in Gujarat. Smoking cessation, again a very critical case for overall cardiovascular risk. Medical nutrition therapy, again for every patient we need to emphasize, not just for good glycemic control. We need to teach our patient about lipid management and medical nutrition therapy. So total carbohydrate should be reduced to less than 50 to 60%. Very difficult for our Indians and Gujaratis. Total fat intake should be reduced to less than 30%. Again, very critical. Saturated fat must be reduced to less than 7%. MUFA and PUFA should be increased up to 15% of calorie. Protein intake, again very missing from our vegetarian Gujarati diet, and it need to increase up to 20% of calories. Increased dietary fibers are very crucial, not just for blood sugar control, but we know via the lipid and biliary reabsorption, the fibers they act and lipid lowering also. And lastly, never forget the glycemic control, which has so much tremendous effect on overall patient outcome. So I thank you everyone for listening to me. Thank you.